Very good morning, doctors. Very good morning. So, welcome to Inicet 2024 IPL Inicet Premier League Surgery second session. So, I think previously we stopped at. Where? So, actually, we are talking about the positive margin, right? We are actually talking about the positive margin, right? So, we'll just finish it off this positive margin. So actually what is meant by positive margin? So what is meant by positive margin? See, the margin is said to be positive when there are some cancer cells present at the edge of this tissue. If there is a presence of cancer cells at the edge of the tissue, then it is said to be a positive margin. And one more thing is, this positive margin suggests that all cancer cells cannot be removed from the area. They cannot be removed from the area. And one more thing is, radiotherapy is given in order to prevent the recurrence. So remember this, what is meant by positive margin means you should remember these 3 points, right? So just leave it off. Now we will discuss what are some of the chemotherapy regimens in breast cancer, right? Actually there are mainly 2 chemotherapy regimens in breast cancer. That is, one is CMF and another one is CAF, right? One is CMF and another one is CAF. What is meant by CMF? It is cyclophosphamide, methotrexate and 5-fluorouracil. What is CAF? It is cyclophosphamide again. A means adriamycin. Adriamycin also known as doxorubicin. It's also known as doxorubicin. Now what is F? F is always the same, 5-fluorouracil, right? So that are the 2 chemotherapy regimens present for breast cancer, CMF and CAF. So cyclophosphamide, M for methotrexate and F for 5-fluorouracil. CAF means A for adriamycin. C and F are the same, right? Now in these 2 regimens, CAF is preferred. CAF is mostly preferred regimen. Okay, remember this, very important. Now how many cycles are given? 6 cycles are generally preferred. 6 cycles of chemotherapy are given. See, what is the most common regimen used? That is CAF. CAF is determines cyclophosphamide, adriamycin and 5-fluorouracil, right? Now if the patient is response to the chemotherapy agent, so it can be continued, or else you can change the agent also. If it's responding, okay, else you change the agent. Now one more thing is, in case of adriamycin resistant breast cancer, for example, it is resistant to adriamycin, the breast cancer is resistant to adriamycin, you can give taxanes. Taxanes are given, right? Now what are the agents in taxanes group? That is docetaxel, right? Paclitaxel, right? So these are the drugs present in taxanes group, right? Now there is a new drug actually which is given in case of adriamycin as well as the taxane resistant breast cancer, that is ixabepilone. It is given in breast cancer which is resistant to both taxanes as well as adriamycin, right? Ixabepilone, right? Now there is another new drug, right, which is actually used as the second line agent for HER2-neu positive breast cancer. What is the drug? That is lapatinib. It is used as a second line agent in HER2-neu positive breast cancer. Now what is the first line then? If lapatinib is the second line, what is the first line agent that is given? That is Herceptin. Herceptin is the first line agent, or you can also call with a name that is trastuzumab, right? It is like an Arabic name. It feels like I'm speaking Arabic, right? Now if a breast cancer is refractory means which is not reacting to any agent, please be on the line. అదే ఇన్ కేస్ ఒకవేళ ఇది పెట్టాలి అని అనుకుంటే రెసిడెన్స్ సర్టిఫికేట్ ఇచ్చేయాలని. రెసిడెన్స్ సర్టిఫికేట్ నేను ఫార్వర్డ్ చేస్తాను, అందులోనే పెట్టాను. వాడు అడిగినవన్నీ నేను అందులో ఫిల్ చేసి పంపించాను. లేదు వాడు అడిగినవన్నీ అందులో ఫిల్ చేసి పంపించాను. ఓకే ఏంటి ఎక్కడ ఉన్నదా ఓకే ఏమన్నా సరే సూపర్. ఓకే ఇది బాగుంది చూసుకొని వచ్చేసేది సరేనా? సరే ఓకే. So what is the first line of agent then, right? What is the first line of agent? That is Herceptin or trastuzumab. Herceptin or trastuzumab, right? You understand it, guys? These all drugs are very important. These all drugs are very important. Surely you will be getting some sort of MCQ on this drug. You will be getting some sort of MCQ regarding these drugs. Please be on the line, just 1 minute. Just 1 minute. I'm having a little bit problem with this mic. Okay, so I'm audible. Yes, I'm audible. Okay, audible. Okay, so that is Herceptin or the trastuzumab. Now, if a breast cancer is refractory means what? For example, if that condition is not responding to any agent, if a breast cancer is refractory, then what you will give? Which drug you will give? You will give a drug called sunitinib. If it's a refractory breast cancer, you give sunitinib. Now we will just discuss randomly the drug with respect to their uses. Okay, for example, first you take the drug, that is the drugs from taxanes group. What are those drugs in taxanes? That is doxycycline and paclitaxel. They are used in adriamycin resistant breast cancer. Remember, adriamycin resistant breast cancer. Now if you take the second drug, that is ixabepilone, it is used in adriamycin as well as taxane resistant breast cancer. Okay, now we will give for another drug, that is lapatinib. Lapatinib is used as a second line agent in case of a HER2-neu positive breast cancer. Right? Now another important drug is, that is Herceptin or trastuzumab. It is the first line agent. Remember, the first line agent is trastuzumab in case of HER2-neu positive breast cancer. Guys, HER2-neu positive breast cancer, the first line agent is trastuzumab or Herceptin, right? Next, sunitinib is used in, we already discussed, if it is a refractory type of breast cancer. Refractory means which is not responding to any agent, that is called as refractory condition. And also if it is metastatic, refractory as well as metastatic. Okay, clear up to this? Okay, now we will go to internet. Now we will discuss 2 points here, very important. And see, we can take sunitinib as the drug of choice for imatinib resistant GIST, gastrointestinal stromal. See, we have gastric induced stromal tumors, GIST tumors are there, no? So for that, the drug of choice, if the GIST tumors are imatinib resistant, then the drug of choice will be sunitinib. Remember, that is one point. And another point is, sunitinib is the first line agent for advanced and metastatic renal cell carcinoma. Sunitinib is the first line agent in case of a advanced and metastatic renal cell carcinoma. Okay, now we will discuss something about the hormone therapy. Very important, guys, very important, right? Now generally estrogen have a positive effect on the breast cancer cells. That means estrogen induces the cancer cell multiplication, right? Now in the body, generally ovary, what is the site for estrogen production, everyone? that is ovary. Ovary is the site for estrogen production. Now the options that are present in case of a hormone therapy are, what are the options? Just we will check right now. Ovarian ablation. Wait, someone might get a doubt like, sir, why are you disturbing the ovary? See, ovary is the production center for estrogen. Now estrogen obviously have a positive effect on the cancer cells. Positive effect means what? Nothing but it induces the cancer cells to undergo multiplication. So the cancer cells can easily multiply, divide, and the tumor as well as the the malignancy condition also increases. So that is why if you just what is that, if you stop the ovary, if you keep some barricade to the ovary, if you just control the ovary by some procedures, we will get to know what those procedures in order to control the ovary. That is ovarian ablation. Then there is something called SERM, selective estrogen receptor modulation. Then something that is AI, means aromatase inhibition, aromatase inhibitors. You know aromatase inhibitors, we will speak in the upcoming lecture. So aromatase inhibitor drugs. Then we also give anti-estrogens. Now these are some of the methods by which we can control or put a barricade around the ovary, so that we can control the ovary and we can decrease the estrogen value, thereby controlling the cancer cells or malignancy cells. Okay. Now first we will come to ovarian ablation. So what is ovarian ablation? Ovarian ablation means simply either going for bilateral oophorectomy, or we can also use LHRH agonists. LHRH agonists. What are those drugs? That is goserelin and leuprolide. These are LHRH agonists. Luteinizing hormone receptor agonists. Okay, LHRH agonists. Or we will also discuss another procedure, that is through SERM. What are SERM drugs? Selective estrogen receptor modulation drugs. Can you tell me what are the SERM drugs? That is tamoxifen and raloxifene. So we can also use SERM drugs to control the ovary. Now the third type of ones are aromatase inhibitors. These are only useful in postmenopausal females. Remember, aromatase inhibitors are only useful in postmenopausal females, right? Now actually these aromatase inhibitors are further divided into two types. One is non-steroidal type and another one is steroidal type. If you ask me non-steroidal type, it is letrozole and anastrozole. Now if you ask me steroidal type, the steroidal type aromatase inhibitors generally includes some agents, or I think it has only one agent if I am not wrong, that is called as exemestane. So steroidal type of aromatase inhibitors include this drug name called exemestane, and the non-steroidal aromatase inhibitors includes, that is letrozole and anastrozole. Okay. Now coming to the final class of drugs to control ovary, that is anti-estrogens. What are anti-estrogens? As we all know, that is fulvestrant drug. Okay. Now we will come to another class of drugs which affect this condition, that is progestins. What are the agents that are included in progestins? First one is megestrol. Second one is MDPA, medroxyprogesterone acetate. Now progestins are actually the drug of choice for hormonal therapy in premenopausal patients. Remember, premenopausal patients. And sorry, not this, not progestin. Sorry, I was confused. Sorry. So actually, the drug of choice for hormonal therapy in premenopausal patients is tamoxifen. What is a tamoxifen? Tamoxifen is a SERM, selective estrogen receptor modulator. Now what is another drug in SERM? That is raloxifene, right? Now drug of choice for hormonal therapy in premenopausal females, that is tamoxifen. Now the drug of choice for hormone therapy in postmenopausal females. Postmenopausal females. What is the drug? That is aromatase inhibitors. What are the aromatase inhibitors? There are two types: non-steroidal, steroidal. Non-steroidal includes letrozole and anastrozole, and steroidal includes something called exemestane. Okay. Now we'll discuss something about tamoxifen, the SERM, tamoxifen. Right. The tamoxifen, what is the dose? It is 10 mg BD for 5 years. Okay. Now what is its mainstream of action? It is a potent antagonistic acting drug. It's a potent antagonistic acting drug on breast cancer cells, right, and also on the blood vessels. It has a potent antagonistic action, right? So can you tell me what is the one of the condition where tamoxifen citrate is avoided in postmenopausal woman? Can you tell me why postmenopausal woman, in postmenopausal woman, tamoxifen drug is avoided? Why? Anyone? Simple logic, common sense. Postmenopausal woman, already there will be decrease of estrogen man. They will be in a hypoestrogenic state. So what is the point of giving tamoxifen? There is no point of giving tamoxifen in postmenopausal woman, so it is avoided in postmenopausal woman. Now tamoxifen also has a partial agonistic action on pituitary, bone, uterus, right, and also liver. So tamoxifen has a partial agonistic action on pituitary, bone, uterus and liver. That is the reason in uterus tamoxifen has a chance to cause endometrial carcinoma. That is why the most dangerous side effect of tamoxifen citrate is causing of endometrial carcinoma. Very, very important. It's a need PG bit, remember. Okay. Now we will come to the rest of the components regarding the breast. Right. Now, what are the lymph node drainage system in case of a breast? What are the levels of lymph nodes regarding the breast? Now actually 5% of the lymph or the lymphatic drains into the axillary lymph nodes, and 15% goes to the internal mammary lymph nodes, as we already discussed. 15% goes to internal mammary, 5% goes to the axillary lymph node, or also we can say like anterior axillary lymph nodes, right? Now if you ask me something like, sir, what are the levels that you previously spoke, something about the levels of lymph nodes, right? So actually there are, wait, I will write clearly, there are actually 3 levels of lymph nodes: level 1, 2, 3. Okay, so what includes level 1? Level 1 lymph nodes are actually located below and on the lateral side of the pectoralis minor. Okay, now what it includes? This level 1 includes anterior group of lymph nodes, posterior group of lymph nodes and lateral group of lymph nodes. Now the level 2 includes which group of lymph nodes? They are located below the pectoralis minor. And what lymph nodes level 2 includes? Very important INSET question. Central group of lymph nodes in level 2 as well as very important nodes called interpectoral lymph nodes. This interpectoral lymph nodes also called as Rotter's lymph nodes or simply Rotter's nodes. Okay, very important. I will just make an underline with red color. High chances to get in INCET as well as NEET PG also. Okay. Now coming to the final level 3 lymph nodes. Level 3 lymph nodes includes, they are actually presented medial and above the pectoralis minor. So present medial and above the pectoralis minor. And what are the group of lymph nodes that it includes? Simple apical. So apical group of lymph nodes are regarded as the level 3 group of lymph nodes. Okay. Okay or not? Okay. What? Why image, man? I already explained each and every part. No, why image? Okay, Yomesh, I'm happy to draw image for you. Now, say for example, this is pectoralis. This is pectoralis minor. Okay, this is pectoralis minor, right? Now we will just erase this one and we'll just right. So this is pectoralis minor muscle. Now here this is the apical group of lymph nodes. Here it is the central group of lymph nodes, and we draw this one, right? Two structures. So here we have anterior, posterior and lateral group of lymph nodes. This one is central, this is apical. Okay, so anterior, posterior and lateral group of lymph nodes are level 1 lymph nodes, and central group of lymph nodes are level 2 lymph nodes, and apical group of lymph nodes are level 3 lymph nodes. Okay, diagram okay. We'll get to the next question, or we'll get into the next portion. Now we will discuss regarding the surgical procedures of breast, that is mastectomies mainly major. So what are the types of mastectomy? The first and important type of mastectomy is simple or total mastectomy. See, in mastectomy topic, what are the questions that are generally asked in INCET? They are the structures that are removed in the mastectomy and the conditions where these mastectomies are done, and the side effects due to these type of mast. For example, if it's total, if it is subtotal, if it is simple. So what are the complications in subtotal type of mastectomy? So these type of side effects on conditions in which these procedures are done, and the structures in which which are removed in these procedures. So that are the questions that will be asked in the INCET. You know, it's actually a en bloc removal of nipple areola skin as well as the breast tissue as well as the breast mass. So all these structures are removed: nipple areola skin, breast tissue and breast mass. They are really removed in the simple or total mastectomy. Now if you come to extended mastectomy, so what are the structures that are removed? In extended mastectomy, the simple mastectomy is performed along with, you will do the simple mastectomy, along with what you will remove? You will remove level 1 lymph nodes, right? So this is done in extended mastectomy. Now one more important and very commonly done, that is modified radical mastectomy. In modified radical mastectomy, we will remove nipple areola skin, and one more thing is we will remove the breast tissue, then we will remove the breast mass plus level 1, 2, 3 lymph nodes, plus we also excise excision of pectoralis major and pectoralis minor, right? So these structures all are removed in the modified radical mastectomy. Once again we will revise. We will remove nipple areola skin, we will remove breast tissue, we will remove breast mass, we will remove level 1, level 2, level 3. All levels of lymph nodes are removed, and we will also excise pectoralis major and pectoralis minor. So that is modified radical mastectomy. Now what is meant? For example, in the modified radical mastectomy, if for example we will done the modified radical mastectomy, but if axillary vein, Bell's nerve, can anyone tell what is Bell's nerve? It's also called long thoracic nerve, also called nerve to serratus anterior. Injury to serratus anterior cause what is the winging of scapula. Okay, so if we spare the axillary vein, if we spare the Bell's nerve or long thoracic nerve, and also if we spare the cephalic vein, so if we spare all these three structures in the breast mastectomy surgery, then that type of mastectomy is called Halstead's radical mastectomy, right? Very, very important mastectomy. Okay, very important, right? The INCT questions will be very tricky. That actually they are simple. There is nothing much magic in it. But what's the tricky part is they will confuse in these options, very nearby options. For example, they will give these options, right? So in the, they'll ask you like in the modified radical mastectomy, we will remove, all are removed except, and they will ask nipple areola skin, level 3 lymph nodes, then cephalic vein and pectoralis minor. So what is not removed in modified radical mastectomy? Cephalic vein. Simple. Now we will discuss something about extended radical mastectomy. Extended radical mastectomy. What is meant by extended radical mastectomy? It is nothing but simply you can remember with a mnemonic, right? RIM. RIM. What is RIM means? R for radical mastectomy plus removal of IM for internal mammary nodes. So radical mastectomy with removal of internal mammary nodes. This is called as extended radical mastectomy. Extended means nothing but you will remove the internal mammary nodes including radical mastectomy. That is called extended radical mastectomy. Now there is one more thing, that is super radical mastectomy. Super radical mastectomy. What is super radical mastectomy? Again we come to what is that mnemonic, RM plus SIM. RM means radical mastectomy plus we also do supraclavicular internal mammary nodes and mediastinal lymph nodes. All these structures are also removed. So that is called a super radical mastectomy. What is super radical mastectomy? Radical mastectomy with supraclavicular internal mammary nodes and mediastinal lymph nodes also removed. That procedure is called a super radical mastectomy. Now we will discuss some of the modifications of a modified radical mastectomy. Some of the modifications in modified radical mastectomy. Now you call it as Auchincloss, which is also same as MRM. Now there is one more modification, that is Patte's modification. Patte's modification, right? So it is the en bloc removal of nippulareolus skin with breast tissue, with breast mass, with level 1, 2, 3 lymph nodes, and also excision of pectoralis minor. Okay, pectoralis minor. Okay. Now if the same removal is done with removal of, this time, a division of pectoralis minor, not the complete pectoralis minor. If this removal is done with the division of pectoralis minor, then it is called as Scanlon's modification. See all these modifications, please listen to the video. I am not writing because it will take so much of time. So just listen to the video and write it down, right? Now, after mastectomy, what is one of the important things that you should keep? Drains should be left at that place. You should keep a drain, insert a drain. Now, what are the types of drains used in mastectomy? One is Romovac drain. Another one is Jackson-Pratt drain. Romovac drain, and another one is Jackson-Pratt drain. Now, if a procedure is done, obviously it will have some complications for sure. Any procedure on this planet. So, what are the complications of mastectomy? Obviously, mastectomy also has some complications, right? The first one is seroma. What is seroma? Anyone? What is seroma? See, whenever we make an incision in the axilla, that will lead to damage of the lymphatics. Always remember, that will lead to the damage of lymphatics. Now this damage to the lymphatic leads to causage of leakage of serum. Leakage of serum or serous collection. You can obviously call it as serous collection or accumulation of serous collection, where beneath the skin flap and axilla. Now this condition is called as nothing but seroma. So damage to the lymphatics leads to leakage of serous collection, accumulation of the serous collection below the skin flaps and axilla. That condition is called seroma. Now actually seroma is the most common complication of the mastectomy. Now, what is its incidence? It is actually seen in nearly 30% of the patients. It is actually seen in nearly 30% of the patients. Seroma. Now, what is another side effect of mastectomy? Necrosis. Obviously, you will have necrosis because you are cutting a lot of tissue, very fragile or very soft tissue, right? Now, for example, if the surgeon who is performing the mastectomy is not very heedful, let us say something like this, is not very heedful, the vascularity of the skin flap will obviously be gone. And what happens is, and then over a period of 2 or 3 days, you will notice that there will be a blackish discoloration. Obviously, you will notice this. There will be a blackish discoloration. Right? Now, obviously, this is a complication of mastectomy. So, that is called a necrosis. Now, one more important thing is, if there is a flap necrosis, then obviously infection will starts to accumulate at the position or at the region. Now, what is one more complication of mastectomy? One more important complication of mastectomy is nerve damage. Always remember nerve damage. So, which nerves are damaged? One important thing is nerve supplying to serratus anterior, and there is also a nerve supplying to latissimus dorsi. These two nerves are damaged. They can be damaged during mastectomy. So you should be careful while performing the mastectomy. Future surgeons, all of you be careful while doing the mastectomy. Okay. Now we already discussed what is the nerve supplying to serratus anterior, also called long thoracic nerve, also called nerve of Bell. If injury to long thoracic nerve causes winging of scapula. Okay. Now what is the nerve supplying to latissimus dorsi called? That is thoracodorsal nerve. Thoracodorsal nerve. Right? Thoracodorsal nerve. Now remember one thing, during the axillary lymph node sampling, while we are doing the axillary lymph node sampling, or we can also call that axillary lymph node as sentinel lymph node biopsies. We can also call it as procedure sentinel lymph node biopsy. Always remember one more side effect is there will be a damage to, there might be a damage to intercostobrachial nerve. Intercostobrachial nerve can be damaged while doing the axillary lymph node sampling. So we can simply call it as like the nerves which are damaged during the following procedures with respect to breast are long thoracic nerve, thoracodorsal nerve, and intercostobrachial nerve. This one is okay. Long thoracic, thoracodorsal, intercostobrachial nerve. Now we will come to the next topic, that is redundant axillary fat pad. So what is redundant axillary fat pad? So some of the patients with a high body mass index, for example if they have a BMI of more than 34, 35, so those type of patients, they mostly suffer from the axillary breast. They mostly suffer from the condition called axillary breast. So what actually, so after the mastectomy is done, some excess tissue which is left in the axillary, so that is, if you just after post mastectomy, the tissue which is remained in the axillary, this is called as redundant axillary fat pad. Right? Now this is also called as axillary breast. This is also called as axillary breast, and it is considered as one of the important complications of mastectomy. This axillary breast is considered as one of the important complications of mastectomy. Okay. So coming to the one more important side effect, that is, you all know lymphedema. Right? So whatever the procedure can be, whenever there is a lymph node dissection, then obviously we already discussed the lymphatics will get damaged, obviously, which leads to accumulation of fluid, lymphatic fluid, which leads to a condition called lymphoedema. All this procedure happens when this lymphoedema happens post-operative period. Remember, right? Post-operative, it will happen, right? Now one more important side effect is angiosarcoma. Angiosarcoma. Just 1 minute, I will drink some water and I will come back to you. Just 1 minute. So I think everyone is listening, okay, like, right? So some of the doctors are getting some, what is this surgery? It is too boring. See, now everything looks boring. But once you enter the MBBS, once you enter the PG, then everything looks colorful. No. I'm joking, guys. PG is really a headache. trust me, it will not be colorful. But if you can try to look into the colorful side of the post graduation, then obviously it is also colorful. Don't think like, oh my god, whether we should go for this or not. No, don't think like that. PG will be colorful on and only if you really enjoy it. But if you simply say like, whether I should take this case, oh my god, why these emergency cases came midnight at 12 o'clock, why the hell I want to hang up with my friends. No, 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 big no for it. Always do your job, then you can have fun, right? You see, there's so many, there will be lady doctors, and you have friends, everything will be there in hospital, man. What you will do by going to home or hostel? What you will do? Nothing. You just sit in the hospital, learn something. You can earn money. Money will bring friends, money will bring lavish, money will bring luxuries, but money can't buy happiness. Happiness you should generate yourself. Happiness is itself which is created by us. Money can't make happiness, but it may buy happiness, like as crazy as it is. But happiness is actually something which you should create yourself, right? So just enjoy your PG, right? I hope and I wish all the students must come out with a bright colors after this Inicet examination. Coming back to the class, we will get into one more important topic, that is angiosarcoma. Now the patients in whom, if we do MRM and radiotherapy, what happens is something like after a period of 10 to 11 years, something like 10 to 11 years, these symptoms may develop. What is that symptoms? Severe pain, or the lymphadenoma which has occurred previously, it may worsen, it will become even more worst, and there will be an appearance of purplish, brown nodules which actually show hemorrhage and ulceration. Sometimes it may also be violet color also. Now this condition is called something that is angiosarcoma. Now this condition in which the patient has developed the angiosarcoma, now this scenario is called with a name called Stewart syndrome. Very, very important for Inicet. You will get an image. Always get ready. You will get a image. And a Nimhan student who wants to get into Nimhans, please be sure with this Stewart syndrome. It's a hardcore topic. Be prepared with the Stewart syndrome. Okay. Now we will discuss something about breast conservation surgery, right? So we will discuss so many procedures, mastectomies, drug treatments, everything. We came to a important component, that is breast conservation surgery. Now this breast conservation surgery, it's actually done in the early stages of invasive breast cancer, that is stage 1, stage 2A and stage 2B. Okay. Now just imagine the 4 quadrants of the breast. See, this breast is not good, this breast is good, it is round, perfect and very good. So imagine the 4 quadrants of the breast, right? For example, if there is a lump and if this lump is excised, then that is called as lumpectomy. Now if there is a lump and this lump is excised with a margin of 1 centimeter around the lump, see, this is 1 centimeter around the lump, if you excise the surrounding tissue also, then that is called as wide excision, or you can also call as wide local excision. So you will remove 1 centimeter margin of tissue around the lump, that is called as wide local excision. But generally 2 centimeters margin will be taken, right? So some doctors say 1 centimeter, but generally 2 centimeters. Now what is quadrantenectomy? Quadrantenectomy means complete excision of 1 quadrant. For example, this is a lump, and if we excise the complete quadrant, then that is called as quadrantenectomy. Okay. Now just think, After breast conservation surgery, a major portion of the breast is left, but even though that breast is left, it may lead to what? It may lead to increase in risk of recurrence. In breast conservation surgery, we will leave some breast tissue, but this breast tissue may lead to increase in chances of recurrence. Now, but we already discussed what we discussed. Radiotherapy, we have a procedure which helps to counteract the risk of recurrence. Counteract the risk of recurrence, right? Now, hence, just remember one thing: all the patients who have undergone the breast conservation surgery, obviously they should be given with the radiotherapy. Now, one more thing is, if there is any contraindication for the radiotherapy, for example, if there is any contraindication for the radiotherapy, then that will be considered as contraindication to the breast conservation surgery also. Remember, contraindication to radiotherapy is also taken as contraindication to breast conservation surgery. Remember. Okay or not? Please tell guys, okay or not? Yes. Now we discussed previously, we discussed contraindication to radiotherapy, but have you ever asked what is the contraindication for radiotherapy? Simple man, common sense. Pregnancy is the contraindication for radiotherapy. Then that implies for breast conservation surgery also it is contraindicated. Okay. Now what are the contraindications for breast surgery? We will just discuss now. Okay. Now if you ask me what are the absolute contraindications, you can simply name it like pregnancy. Then if there is 2 or more than 2 tumors in different quadrants, and if there is diffused malignant appearing microcalcification, then it is a absolute contraindication. And one more thing is, if there is a persistently positive margin, then that is also absolute contraindication. And one more thing is, if there is history of therapeutic radiation exposure, this is very important. If there is history of therapeutic radiation exposure, then that is the absolute contraindication. But what are some relative contraindications? Relative contraindications, you can simply say it like, for example, if the patient has a history of collagen vascular disease like scleroderma, acute lupus erythematosus, then it is a relative contraindication, right? Then you can also take when there are multiple tumors, which are in a same quadrant, and if there is an indeterminate consideration regarding calcification, then it is a relative contraindication. Then if the tumor is large, in a small breast, then it is a relative contraindication. And if there is a centrally located tumor, right, if that tumor which is centrally located beneath the nipple and areola, and if the obviously the tumor will be locating just near to the nipple and areola, and hence the nipple and areola may also have to be excised along with the tumor. So since it is an arduous to reconstruct nipple, this is considered as a relative contraindication. See, you understood or not? For example, if I will show it here. Wait, I'll draw a breast. This is not good. I'll draw a breast here. For example, this is areola, this is nipple. If the tumor is situated like this, then obviously you should remove the areola, and sometimes you should also remove the nipple. So obviously this condition appears like it is a relative contraindication for breast conservation surgery. Okay. Now what you will do if in case of these contraindications? So in case of all these absolute and relative contraindications which we have discussed right now, in all these conditions, what you will do? In these conditions, instead of breast conservation surgery, you will do simple mastectomy, also called as total mastectomy. So instead of breast conservation surgery, in all these contraindications, absolute as well as relative, you do simple mastectomy or total mastectomy. Now we will come to the breast reconstruction. Very, very important INICT topic, guys. Please listen carefully. I am begging you. Very important INICT topic. Breast reconstruction. Breast reconstruction. So breast reconstruction is of three types. One is autogenous, second one is alloplastic, and third one is combined. Autogenous, alloplastic, and third one is combined. So what is autogenous? Autogenous, you all know that if a person, let us say she is having a breast cancer, so this person's own tissue is used for the reconstruction, then that is called a autogenous. Now what are the flaps used regarding the reconstruction, guys? This is very important question. It is an INICT, but mostly NEET PG also they are giving. First one is tram flap. Tram means anyone transverse rectus abdominis muscle flap. It is the most commonly used muscle flap for breast reconstruction. Another one is LD flap. LD means latissimus dorsi. Next, another one is thoracoepigastric flap, then lateral thigh flap, gluteal flap, and one more important flap is Rubens flap. Rubens flap. What is Rubens flap? Right? Rubens flap is something which is based on the deep circumflex iliac artery. Okay, that is Rubens flap. Okay, now coming to the tram flap. So what are actually collected in the tram flap? Transverse rectus abdominis muscle flap. So we will incise, or we will collect skin, fat, and a portion of rectus abdominis muscle, Now the tram flap is actually based on inferior epigastric vessels. Remember, it's based on inferior epigastric vessels. Now an anastomosis, we actually perform an anastomosis between the inferior epigastric vessels and the internal mammary vessels. Remember this, we will just perform an anastomosis between inferior epigastric and internal mammary vessels. Now actually tram flap is a free flap. Why? Because it is devascularized from the donor side and revascularized at the recipient bed. You understand? The tram flap is a free flap actually, because it is devascularized from the donor side and revascularized at the recipient's bed. Now tram flap is the most commonly used flap. You just remember that, right? That's very important short, right, for breast reconstructions, right? Now sometimes while you are sometimes while you are excising the tram flap, it may lead to hernia, and hence it cannot be considered as the best flap to perform breast reconstruction, right? So even though you think like tram is the most commonly used flap, but it is not, it cannot be considered as the best flap to perform breast reconstruction. Now if you ask me, sir, if that one is not the best flap, then which is the best flap? That is DIEP. DIEP is the best flap. What is meant by DIEP? Anyone? It is deep inferior epigastric artery perforator flap. Deep inferior epigastric artery perforator flap. Now what is the difference between tram and DIEP? Deep. What is the difference between tram and deep? So in tram what we do is we simply take skin, fat, muscle, whereas in deep the abdominal muscles are spared. That is the difference. Okay, so actually I will drop you some couple of images after the completion of this session, so you can understand what is being done, what is being not done, everything will be understood. Okay. So always remember, the abdominal skin and the fat are based on deep inferior epigastric artery perforator. Okay, just remember that one. Okay, now what is the muscle spared in the DIEP flap? Which one? Abdominal muscle, right? Now previously we discussed what is the risk regarding tram flap. Anyone? Just a small reminder. What is the side effect or complication? Hernia. But this hernia is not seen in DIEP flap, whereas in tram it is the side effect. Okay, or it is considered as the complication. So that is the reason DIEP flap is considered as the best flap for breast reconstruction. But what is the most common flap used? Tram. See, it is like this thing we can compare. This comparison we can do like, see, trendy, very posh or very fluently speaking, or something like hi-fi women, they may attract men or they may attract boys, but ultimately boys will love traditional women only, traditional girls only. That is an open secret. So that is the same reason. Even the traditional women, they have some headstrong. I am not speaking low about them, but still I am just speaking like even the traditional women have some headstrongness, and even if they talk like hitting with a whip, even they talk like that, but still that appears, that gives even more attractiveness to the boys. That headstrongness only give even more attractiveness to the boys, whereas some of, the girls, the fashioned, highly fashioned, hi-fi girls, they may attract men or boys, but still the traditional women or the traditional girls will have a higher hand, upper hand regarding that condition. So same like that, the tram flap, it might be the most commonly used flap, but obviously the DIEP flap is the best flap, remember. Okay, so coming to the LD flap means latissimus dorsi flap. Now what are the parts exercised in that? Same, skin, fat, latissimus dorsi. Now what, after the excision is done, we just create a small tunnel. Okay, so after creating the tunnel, we will just use the myocutaneous flap for the breast reconstruction. Now the important point here is the LD flap depends on thoracodorsal vessels. Very, very important. Thoracodorsal vessels. Whereas previously we discussed what we discussed, tram flap is based on, very important guys, inferior epigastric vessels, whereas latissimus dorsi flap is based on thoracodorsal vessels, right? Now we will discuss something about alloplastic flap. We discussed autologous right now, autogenous flap right now. So right now we will discuss about alloplastic type of flap. Now alloplastic flap reconstruction means we use synthetic, right? Alloplastic means we use synthetic flap. Synthetic flap. Now what these synthetic flaps or implants are made of? Either they are silicone gel or they are silicone gel with saline refills. Okay, either they are silicone gel or silicone gel with saline refills. Now this type of breast reconstruction method opted for most of the commonly worldwide, and silicone implants are used for this, right? So most commonly worldwide used type of breast reconstruction method is alloplastic type only, in which they use the silicone implants. You heard about Angelina Jolie, everyone? You heard about Angelina Jolie? Angelina Jolie is a famous Hollywood actress. She has undergone breast reconstruction surgery, and she was implanted with silicone implants, and finally right now, due to all these surgeries, due to all these implants, she is right now affected with cancer, breast cancer. Actually, previously only she had breast cancer. For that, mastectomy was done and breast reconstruction was done with the help of silicone implants. After implanting the silicone implants, her condition even more worsened, even more it worsened. Right now she is going on through a very tough process. She has lots and lots of crores of rupees, but she doesn't have health. She is old enough. I think the recent series Immortals, I think in the Immortals you can watch her. She is old enough. But I can say one thing, she is not our old Lara Croft Tomb Raider. Our Lara Croft has become old now. She is old enough that she should take some rest from movies. Okay. Have you seen the movie Lara Croft Tomb Raider? Very nice movie. Please watch. Everyone watch all the 3 versions of Lara Croft. Right? Very beautiful movies. Lara Croft. These are actually adventure movies, like this guy his name is Indiana Jones. Indiana Jones, I think it has 6 sequels or 5 sequels. So like that, this Lara Croft has also have 3 sequels. One of the last sequel that came in 2021, I think, right? 2021 or 2022 you got the last sequel, but just watch it, man. Those are damn good movies, right? Okay, enough of this Hollywood. Then we'll come back to the silicone implants. See, not much we need about silicone implants. You all know it. So what we do is we will clear the breast tissue. I'll just show you a small diagram. With that we will just end the silicone implant. These are some nice breasts. So we will just remove all this tissue. Then after that what we'll do is we will just keep a silicone implant here. Right. Now this is a silicone implant. See, this is a silicone implant. We'll just keep so that the breast hangs freely and it gives a good shape to the breast. Right. Now here the breast is actually present in front of the muscle. This is muscle. This is implant. Right, here the implant is present in front of the muscle, but there are conditions where you can do the procedure in another way. For example, this is breast and you take it like this is muscle, and sometimes here you will keep the implant. This is implant. Now this is called a implant behind the muscle. Implant behind the muscle. This is muscle. This is muscle. Okay, understood? Sometimes you keep implant in front of the muscle, sometimes you will keep at the back of the muscle. So most commonly used silicone implants. We do breast implantation, breast enlargement, breast augmentation. So actually patient will undergo some serious procedures. They will be do an incision, they will keep the implant, or after that you will just go on with the sutures. So it's as simple as like that, right? Okay, no need to get on to all this details, right? Now I just want to tell you only one thing. See, for example, if the female has small breasts, very little breasts, and if she is opting for breast enlargement or breast augmentation, obviously the implant is placed in front of the pectoralis major muscle. But if a female in whom mastectomy has already been done, and if she is going for breast reconstruction afterwards, something like our Angelina Jolie, then the implant will be placed beneath the muscle. So this one, right? So this condition, I will write it in red color. This condition is done in post-mastectomy individuals. Post-mastectomy individuals who want to go for breast reconstruction surgery, breast reconstruction surgery. If they want to go for breast augmentation, that one. And this one is done in females who have small breasts, and if they want to go for breast augmentation or breast enlargement, then the implant is placed here, see, in front of the muscle, here. Okay. So just remember one thing regarding the placement of breast implants: for augmentation in front of the muscle, for reconstruction behind the muscle. So young girls who are in nice good age, in front of the muscle. In old women who are finished everything in their life, you will keep behind the muscle. Okay. Now there is the combined method in which both the synthetic implants as well as the own tissue, the patient's own tissue, both are used in combined breast reconstruction, right? So what are the combinations that are used? The combinations that are used are tram flap plus implant, or you can also use one more combination, that is LD flap plus implant. Now this is called a combined method of breast implants as well as reconstruction. Now certain females, they have larger breasts, right? Actually they have larger breasts, so the flaps alone, they cannot restore the symmetry of the breast because of larger breast size, very large, like big books they have. So because of that, what the surgeons do is they do a combination of flaps with implants, right? They do a combination of flaps with implants are used in the women who have larger books. Okay. So remember, now we can simply say like combined method of breast reconstruction is used in female with large breasts or books. You can call anything large breasts or books, right? Now coming to the final thing, that is breast cancer follow-up. Breast cancer follow-up. See, I am going through each and every topic which is important for Inicet. Okay. Now regarding the follow-up, we will just do for the first 3 years, we will do for every 3 to 6 months of follow-up. From 4th to 5th year, we do follow-up for every 6 to 12 months, and after that it is done annually. Okay. 1 to 3 years, for every 3 to 6 months we do follow-up. 4 to 5 years, for every 6 to 12 months we do a follow-up. After that you will do annually. Now mammography is also done annually. Now if the patient has received radiotherapy, mammography should not be done prior to 6 months. If the patient has received radiotherapy, mammography should not be done prior to 6 months. Remember, prior to 6 months. Okay, that one. Now self-examination, most of the doctors, you might know, it is done monthly. I think the women will look themselves into their bathroom naked, in the mirror, and they will just palpate their breasts in each of their quadrant: upper middle, upper medial, upper lateral, lower medial, lower lateral. They will just check the 4 quadrants. That's it. Pelvic examination is also done manually. Remember this is also important. Pelvic examination is also done annually. Now with this we also coordinate some sort of caring between various sections regarding all sort of departments. So all sort of follow-up care we should done, and routine surveillance of the breast cancer patients also should be done. And remember one thing, some of the following investigations, they are actually not done. What are those investigations? Blood surveillance, which includes CBT and LFT. These are not done. And imaging which are not recommended, right? Chest X-ray, ultrasound liver, MRI breast, bone scan, PET scan, CT scan, these are generally not recommended. Okay. Now one more thing that are actually not recommended, right? Because most of the doctors they make this mistake. The tumor markers are also not recommended. Which tumor markers? Carcinogenic embryonic antigen, and also one more thing is carbohydrate antigen. These two are not recommended. So all these imaging, all the blood surveillance, and these two tumor markers are not recommended, right? Now what are some of the prognostic factors? If you come to the breast cancer, what are the most important prognostic factor in most of the malignancy is defined by the stage of the condition, right? Is the stage of the condition, and the components are TNM, tumor nodal metastasis. Okay, tumor size, node spread, and metastatic spread, TNM, right? But there are two exceptions for this regarding this statement which we have spoken, right? What we spoke, most important prognostic factor in most of the malignancies is staging, as it consists of tumor nodal metastasis. But what is the exception for this rule? Number one is Wilms tumor. Very important, remember, Wilms tumor. Right? In Wilms tumor, what is the most important prognostic factor? Can anyone tell? Histology, followed by staging. Okay. And can you tell me if there is any other exception for this? Yes, there is also one more exception, that is sarcomas. Which sarcoma? Soft tissue sarcoma. Soft tissue sarcoma. Now what is the most important prognostic factor in soft tissue sarcoma? Anyone? It is the tumor grade. Okay or not? Now we will discuss what is the single most important prognostic factor in breast cancer. Yes, it is TNM. Yes, you said it right. But what is the single most prognostic factor in TNM itself? Anyone? Axillary lymph node status. This is very important, guys. This is the most important prognostic factor, right? Now for example, if the patient has a metastatic breast cancer, then obviously the ER/PR status determines whether the patient will respond to hormone therapy or not. Please remember this statement. If she is having a metastatic breast cancer, then the ER/PR status will determine whether the patient will respond to hormone therapy or not. Now what is the most important prognostic factor in breast cancer? What is the most important prognostic factor in breast cancer? That is staging. Right? Staging. Now in the staging if someone asks what is the single most important prognostic factor, we already discussed, that is axillary lymph node. Okay, so obviously staging is the most important prognostic factor, but in the staging if someone asks you what is the single most important prognostic factor for breast cancer, then it will be axillary lymph node status. Okay, now what is the most important prognostic factor in ER/PR in metastatic breast cancer? Most important prognostic factor in metastatic breast cancer, it is ER/PR status. That is the most important prognostic factor in metastatic breast cancer. Now have you ever heard about an index, a prognostic index we use in this condition called Nottingham's prognostic index. Anyone? Have you ever heard? This Nottingham's prognostic index is calculated by 2 into tumor size, 0.2 into tumor size plus lymph node stage plus tumor grade. Okay. Now, why this Nottingham's prognostic index is done? It is done to select the patients for adjuvant treatment. This status is calculated to select the patients for adjuvant treatment. Okay, leave it off. And there is one more grading called Bloom-Richard grading. That is Bloom-Richard grading. Bloom-Richard grading. So, what are the things that are present in Bloom-Richard grading? You remember with T, N, M. T for tubule formation, N for nuclear pleomorphism, and M for mitosis. Mitosis, nuclear formation, nuclear pleomorphism, and tubule formation. This is called as Bloom-Richard grading. Okay. Now, there is one more prognostic index called Van Nuys prognostic index, right? For example, whenever a person is having a ductal carcinoma in situ, obviously excision must be done. Now, if it is a high grade carcinoma, apart from lumpectomy, what you should also do? Radiotherapy. Why? In order to prevent the recurrence. Now, the Van Nuys prognostic index is actually for those patients suffering from DCIS who do not require radiotherapy. That is important statement. Okay. Now, it is based on the following components. Remember, the Van Nuys prognostic index, it's actually based on the following components, and you can remember it with a mnemonic, that is micro swag. Okay, what is meant by micro swag? Micro means micro calcifications, and swag means S for size of tumor, W for width of the margin, A for age of the patient, and G for grade of the tumor. Now, these components include in Van Nuys prognostic index. Now, this is actually for those patients suffering from DCIS, but they do not require radiotherapy. Okay. Okay. Now, coming to important aspect, that is sentinel lymph node biopsy. Previously, we had discussed, right? Sentinel means anyone? Gatekeeper. Sentinel means gatekeeper. Now, what is meant by sentinel? See, what is the first thing that we come across when we go to a home or we go to a house? What is the first thing we see? The gate. Obviously, the gate is the first thing that we come across when we go to someone's home, neighbor's home, friend's home, lover's home, affair's home. The first thing to come across we see is the gate itself. When we open the gate, we will enter into the home. So that gatekeeper is also known as sentinel. So the first lymph node that receives the lymph directly from the tumor itself, that is called as sentinel lymph node. Now you got it, what is meant by that? I think one of the doctor yesterday, she has dropped me a question like, I think she is a third year student if I am not wrong, because if someone asks the definition of sentinel means either he or she did not go to the classes of pathology, or he or she is actually studying the pathology, right? So anyhow, doctor, whatever you want to ask, you can ask me, no problem. I am trying to tell the answers. Sentinel lymph node is the first lymph node which come across the lymph drainage from the tumor directly itself. That is called a sentinel lymph node. Sentinel means gatekeeper. Okay, so that is called a sentinel lymph node. So it's also called as gatekeeper's lymph node. Now, the concept of sentinel lymph node was actually done by Cabana. As a scientist, For which condition first time this was done? This was done by Cabana, and it was primarily done first time by Cabana in carcinoma penis. Carcinoma penis. The sentinel lymph node was first time taken in carcinoma penis. Now this is also called as, hence that's why if we do the sentinel lymph node in carcinoma penis, that is called as Cabana's procedure, because the person behind this procedure is Cabana. Now what are the roles that are established in sentinel lymph node biopsy, right? That are established by sentinel lymph node biopsy. Mainly it is done in carcinoma breast, carcinoma penis, malignant melanoma, head and neck malignancies, and carcinoma vulva. Carcinoma vulva. Okay. Now if someone asks you what is the sentinel lymph node biopsy in relation to its breast, right? So actually clinically actually they should be non-palpable and negative clinical indication, right? So the sentinel lymph node generally includes two techniques. Remember, the sentinel lymph node, it generally includes two techniques. Listen carefully guys, chances are there that this might come in the exam this time, that's why I am telling two techniques. What are those two techniques? First one is blue dye method. First one is blue dye method, and second one is radioactive colloid technique, right? This radioactive colloid technique is most commonly used. Remember, radioactive colloid technique. Now, what is radioactive colloid technique? In which we use technetium-99 labeled sulfur colloid. We use technetium-99 labeled sulfur colloid. And in blue dye technique, what is the dye used? That is 1% lymphazurin. That is 1% lymphazurin. It is also called isosulfan blue. Here you use technetium-99 labeled sulfuric acid. H2SO4 means nothing but sulfuric acid. Don't panic, okay? Sulfuric acid. Now, if you ask me the maximum detection rates which is observed in that, if both techniques are combined, it's obviously you get a higher result. So the maximum detection rate is observed when both the techniques are combined. So it can be seen in both the conditions also, whatever it is, right? So what we do is we inject the dye or radioactive colloid around the tumor or around the areola, but remember, it is not injected around the nipple. Very, very important. It is the INICT question. The dye or radio labeled content is not injected around nipple. Around nipple. Okay, that's important. Now the dye that is injected in the breast, it directly goes to the gatekeeper lymph node via the lymphatics. Obvious, right? Now after giving it, you will just experience, or you will just observe that you will get some changes there, and in majority of the breast cancer patients, the number of sentinel lymph nodes are generally more than one. That is one important statement you remember, right? And one more thing is, the surgeons use a special probe to detect all this procedure, that is called a gamma probe. I think if you go to the surgical OT theater, you will be, if it is a breast oncology dealing OT theater, obviously you will see this gamma probe there if you go to that, right? Now using the gamma probe, the surgeon can easily detect the radioactivity in the injected area near the sentinel lymph node region, right? Now as the radioactive substance is also injected around the tumor via the lymphatics, the radioactive substances is taken to the sentinel lymph node, and through the probe itself where we detect the maximum radioactivity, then that one can be identified as the sentinel lymph node, right? So it is as simple as like that. Now if you, after the localization is done, what they do is simply the tumor is excised from the sentinel lymph node. Okay, so actually I have some couple of images, so I will drop it down, no problem with that. Now what will the surgeon do after excising the sentinel lymph node? It will be sent to the pathology department, right? It will be examined, right? So obviously after that biopsy, they will give some report whether the sentinel lymph node is negative or positive, whether it has any changes, right? Everything will be given. Okay, so what it appears after giving the dye, how it appears during the resection? The sentinel lymph node appears in blue color. Why? Due to injection of the dye, because it takes that color, so it appears in a blue color, so that the sentinel lymph node will be easily removed and it is carried with the histopathological examinations. Now what are the contraindications for sentinel lymph node biopsy? Now this is important. What are the contraindications for sentinel lymph node biopsy? This is something very important. First one is if there is any non-palpable lymph node in the axillary region, non-palpable axillary lymph nodes. Second one is if there has been any prior axillary surgery. For example, previously the patient has undergone for surgery in that axillary region, or if there is any prior axillary surgery, or if the patient has any history of chemo or radiotherapy. And one more contraindication is if the patient has multifocal lesion. Remember this, very important. Patient has multifocal lesion. Obviously if the patient has multifocal lesion, then it will be difficult for the surgeon to find out the sentinel lymph node. It's an obvious thing, common sense thing, no need to explain it. Okay. Now what are the complications of sentinel lymph node? Are there any complications for sentinel lymph node biopsy? Of course there are. First one is skin tattooing complications. I will write here. First one is skin tattooing. This is one of the most important complications. Then sometimes it may lead to necrosis. Sometimes it may lead to urine discoloration. Sometimes it may lead to anaphylaxis. Sometimes it may also cause very important intercostobrachial nerve injury. Very, very important. And one more important thing is, what is the most common nerve injured? Most common nerve injured during sentinel lymph node. You will get a question, that is intercostobrachial nerve injury. Okay or not? Okay or not? Okay or not? Okay. So we finished all types of things. Finally we will discuss something about inflammatory breast cancer. Please be on the line. Just wait.